Thanks, Damien. Good morning, everybody. It's very much a pleasure for me to be back in Bern. Thanks to Moritz and Klaus and the whole team for making us feel at home here. It's always a great pleasure to be here. I learn as much as I teach when I come to this meeting, and very much enjoy it. And it's also a privilege to be honoring Dr. Millis, who's been a great mentor to many of us. So it's really a fun time to be in Bern. I'm going to talk to you about a new tool to help quantify correction at the time of PAO. I am conflicted in this presentation. This is a company called OrthoGrid, and I've helped them develop this project, and I'm on the board for their company at this time. So here's the question: how do we measure PAO correction? As you saw the case this morning, I think traditionally, and still for most surgeons today, we eyeball correction. So we get our postoperative or intraoperative x-ray and we look at it and we kind of go, all right, LCEA looks pretty good, ACA looks pretty good, but it's really been historically an eyeball situation. And when you think about the magnitude of this operation, we go through a tremendous amount of intraoperative execution of the bone cuts, and then the real critical part is positioning the acetabular component, and perhaps in 2020 we can do better than just eyeballing correction. So historically, this is me on the left, we eyeball the correction. This is Dr. Millis in the middle during a PAO, and there is pretty good evidence that surgeon skill and especially experience allows us to get better at judging acetabular component position over time. But again, what I would submit to you is we can probably do better in 2020. Now, Jim Wiley helped us look, he's here in the audience with us, he helped us look at validation of operative fluoroscopic correction compared to our postoperative x-ray, basically trying to validate that using C-arm to judge intraoperative correction was a valid way to do this as opposed to getting intraoperative x-rays. We published this paper in 2016 that showed relatively high correlation coefficients for judging intraoperative fluoroscopy-based correction of our acetabular fragment, and it was fairly accurate in predicting what we would see in our 6-week postoperative film. Now, there's been a couple attempts to use devices to quantify acetabular positioning in the literature. This was Khaled Sabali developed this technique that he published in 2008. This is what he did. He put pins in the anterior superior iliac spine and then attached a protractor basically to that. And you can imagine today, most of us don't find the idea of putting pins in the iliac crest very attractive, but at least this was an attempt to try and use a quantitative tool to measure acetabular correction at the time of PAO. But as I've said, perhaps there's a better way to quantify correction. Hopefully the ideal tool would be efficient, it would involve minimal workflow disruption, and it would address some of the limitations of fluoroscopy such as distortion and image transfer. A lot of us I didn't understand this until I started to really get involved with this company, but distortion with C-arm fluoroscopy is actually a significant issue. Because of the curved nature of the detector, because of electromagnetic fields in our operating room, and because from room to room these electromagnetic fields can differ, distortion's a real issue. And I'm not an expert in it, but I'll just give you a couple examples of distortion. So because this is an example of parallax distortion, again, because the image intensifier is curved and we get a linear image coming into it, there's some deflection, and this can cause some intrinsic errors in the C-arm images that we get. So I think all of you have probably seen cases where you put a hip screw in a femoral head and it looks perfectly in the center on fluoroscopy images, and yet postoperative x-rays show it to be quite different. This is an example of line of sight parallax. So a driver, for instance, sees the speedometer slightly differently than a passenger does, an example of parallax distortion. And there are a number of other distortion types such as pincushion distortion, S distortion, which is due to electromagnetic field differences in our operating rooms. All of these things can contribute to distortion of our fluoroscopic image. This is an example of a hip replacement. This technique can be used very effectively for direct anterior hip replacement. And you can see the distortion of those grid lines, which should be very perpendicular squares. You can see the curvy linear nature to them, and that is a reflection of distortion in the C-arm fluoroscopic images. My partner, Jeremy Gilliland at the University of Utah, has done some really nice work looking at differences room to room, and they can be as much as a couple millimeters in hip replacement. And so this is an example of now using a distortion correction algorithm and a digital protractor. This is actually intraoperative picture showing the distortion feature of the system being turned on and off. Here's the digital protractor being used to assess or quantify lateral correction. It's a fairly simple OR setup. This is a screen connected directly to your normal C-arm unit. It can be operated by an independent person, or it can be operated by some member of your operative team. For instance, my PA with a sterile field can actually press buttons on this unit and operate the measurement tool on their own. So this is what we look at. We look at pre-op and post-op measurements. This is kind of the workflow. We first get an image. The image is corrected for distortion. We then place some horizontal reference line, either interteardrop or ischial tuberosity based. We then get an AP of the hip, and we can then bring this digital protractor onto the field and get a better quantitative assessment of the degree of lateral coverage. So we're doing this preoperatively. You can see the menu drop-down feature allows us to select first LCEA. Now we're doing acetabular index. And you can see in real time we get some very nice quantitative measures of acetabular morphology. And here on the simulated lateral view, we're doing the same thing for anterior center edge angle. And we can do this with other measurements as well, such as the alpha angle. Here's the ACA being measured. We get a very precise center of head measurement. And we can do that preoperatively, and then after execution of the PAO, we can then correct the pelvis again in terms of inlet, outlet, and rotation. And then in our post-operative correction, we can do the same measurements and compare them in real time to the preoperative measurements that we've made. So that's kind of the workflow that we use. Today, we can also have a feature allowing us to measure the anterior and posterior wall indices. And you can see it will populate a ratio there in their upper right screen. Just get a better idea of quantification of the acetabular version at the time of surgery. So what we did is a study to correlate preoperative and intraoperative fluoroscopic-based measurements with the fluoroscopic tool that corrects for distortion, and we compared that with postoperative plain film measurements. So this was an IRB-exempt prospective study. We looked at all our PAO cases that we did from November 18 to December 2019, all done by me, 40 hips. Here's the patient characteristics, fairly typical demographics, highly predominant female population, predominantly thin people, average age 23.5. This is what we measured. We measured the lateral center edge angle, the acetabular index, the anterior center edge angle, the alpha angle, and the posterior wall sign. And we did this on the intraoperative fluoroscopic measurements and compared them to the preoperative and postoperative standing radiographs that we obtained 6 weeks postoperatively. We did the typical statistical analysis using concordance correlation coefficients, basically reproducing the study that Jim Wiley did in 2016. Here's the take-home messages in terms of data. You can see on the very top, we compare a preoperative radiograph to the preoperative fluoroscopic grid measurements, and we get very high correlation coefficients in the range of 0.7 to 0.8. We compare in the middle there postoperative fluoroscopic grid measurements to postoperative radiographs obtained in the PACU. Again, very high correlation coefficients. And then probably most importantly, we compare postoperative fluoroscopic grid measurements to the 6-week radiograph, and we get very good 0.67 to 0.72 correlation coefficients indicating very good reliability. We also looked at inter-rater reliability at 6 weeks, and we saw almost perfect agreement with a concordance coefficient of greater than 0.8 on nearly all readings. The only one that had slightly less sensitivity was the posterior wall sign. Here's just another case example. On your left, that you can see the preoperative condition in LCA starting at 9, moves to postoperatively to 31. We get a fairly precise measurement and probably a little bit better than what I can eyeball. I certainly have changed how I assess correction using this tool, and I feel like I'm a little bit more precise. On the bottom, you can see the acetabular index measurement. So in terms of discussion, this was our original paper, again, the Wiley paper showing concordance correlation coefficients in the range of 0.7 or so. In the current study, when we look at inter-rater reliability, we get even a little better. We get into that 0.8 and 0.9 range. So it indicates that from surgeon to surgeon, there's probably a very good chance that they can accurately use this tool to help them with postoperative correction of the acetabular fragment. So in conclusion, I think our study validated the use of a novel intraoperative fluoroscopic tool that does account for distortion. It permits real-time measurement of PAO fragment correction that correlates accurately with the postoperative radiograph. And I do think this tool adds value by giving surgeons a reliable quantitative measurement of correction without interfering with the surgical workflow. Thank you very much.